All right, welcome back, everybody. Our next talk this afternoon is by Dr. Knipe, one of our ILD researchers here, who is going to give us a talk on hypersensitivity pneumonitis.
Great. Okay. Thank you so much, Dr. Frank. So I'm happy to be here today to talk a little bit about hypersensitivity pneumonitis, an interstitial lung disease induced by environmental exposures. So as the title said, we're going to talk about some pigeons, farmers, and hot tubs today. Okay, I have no disclosures, and I'm going to start just a brief outline. I'm going to start with a case presentation, introduce hypersensitivity pneumonitis, talk a little bit about what we know about pathogenesis, including the immunopathology of HP, how we diagnose the disease, and what our current regimen is for treatment. Okay, so let's jump in. So for a case presentation, we have a 50-year-old woman who was a never smoker who presented to her primary care physician with progressive dyspnea on exertion, non-productive cough, and fatigue over about 3 months. In talking to her and getting a clinical history, she revealed that she actually has a hobby of rehabilitating pigeons in her home. And so the pigeons are living inside the house with her. Although over time, she has limited them to one room in the house, so she's not with them all the time. And on exam, you find that she has bilateral diffuse fine crackles on auscultation. Her labs are all normal, and pulmonary function tests reveal a reduced FVC and reduced DLCO, so suggestive of a restrictive deficit and a diffusion deficit. She had a chest X-ray done, which showed bilateral, interstitial, and patchy opacities. So because the chest X-ray was abnormal, she was sent for a high-resolution CAT scan, which showed patchy ground glass opacities with a mid-lung zone predominance, some mosaic attenuation, and air trapping. She had both inspiratory and expiratory views done. So I start with this case presentation really to set the stage for our discussion today. And to introduce the concept of hypersensitivity pneumonitis. So this case is a very classic presentation. I intentionally mentioned that she had a lot of exposure to pigeons, should really make us trigger the thought of the diagnosis of HP. Not always this classic. Unfortunately, it's rarely this classic, but it's a good example of just things to look for and things to ask about. What is hypersensitivity pneumonitis? It's an airway-centered inflammation induced by a really exaggerated immune response, usually to an inhaled foreign substance. It's a syndrome that results from, we think, repeated exposures to a variety of mostly organic particles, but also some inorganic particles. And although I'm going to focus a lot on trying to identify inhaled antigens, up to 30% of cases have been reported to have no identifiable exposure, which can make diagnosis challenging. But the thought is really that this is one of many diseases that result from a two-hit hypothesis, so that there's some antigen exposure on top of some genetic predisposition resulting in disease. So to get into a little bit of that, HP develops in response to inhaled antigens, we think. So under normal conditions, we all inhale antigens. Here's the antigens kind of going into our alveolar spaces. They're recognized by a surveillance immune system that's constantly surveilling in the lungs. And most of the time, they recognize the antigen, but we develop tolerance to it. And so we don't get disease as a result. They clear that antigen or they develop tolerance to it. But in some predisposed individuals with either genetic or environmental promoting factors, we believe, there's an antigen-specific lack of tolerance. And instead, the immune system gets activated. We get inflammation, including granuloma formation, influx of immune cells, and in some cases, ultimately, the progression to fibrotic scarring of the lungs. Historically, HP was divided into 3 categories: acute, subacute, and chronic, and this reflected the duration of time from antigen exposure to the development of disease. But this was very difficult to determine in many cases how long someone had been exposed to the disease before they developed symptoms. So these lines were very blurry. It became clear over the years that really the primary determinant of prognosis was the presence or absence of fibrosis. And so therefore, there's been a recent push, including in the ATS guidelines, in the Blue Journal in 2020, to divide HP really into 2 categories: non-fibrotic and fibrotic. And so these are the categories I'm going to sort of talk about throughout the rest of the talk. So as I mentioned, HP is an immune-mediated reaction to a variety of inhaled environmental antigens. These can be found at home, at work, or through various hobbies. There's a huge list of HP inducers that have been reported, but they can mostly be separated into kind of three main groups. Animal antigens with a heavy influence, heavy representation from bird antigens, like pigeons and parakeets can top in the list there. Microbes, including fungi, molds, and bacteria, and then chemicals, including solvents and some drugs. And I'm going to keep repeating this sort of theme that trying to identify the source can be really helpful for management. So here's a short list of some of the most common HP inducers, including bacteria and moldy hay that cause farmer's lung, mycobacteria such as Mycobacterium avium complex responsible for hot tub lung, feathers, excrement from birds responsible for bird fancier's lung, and some of the chemicals that have been implicated in HP, including toluene and isocyanides found in paint and varnish. So I'm going to go through a couple of categories of antigen inducers of HP. The top one being farmer's lung is one of the most common forms of HP. The main source of antigens include bacteria, such as thermophilic actinomycetes in moldy hay. And interesting that as I was reading, the round bays of hay tend to have higher humidity and increased microbial growth, and so they tend to be stronger inducers of HP. Just make a note that that farmer's lung is distinct from a febrile toxic reaction to inhaled mold dust, also known as organic dust toxic syndrome, which is a non-immunologic disease more common than HP, but doesn't result in the progressive inflammation and fibrosis that we see with HP. HP can also be induced by exposure to bird antigens, and often this is feathers or excreta or other proteinaceous material from pigeons, parakeets, canaries, chickens, turkey, other fowl. Many birds have been identified or implicated or suggested to lead to HP. The antigens can spread by aerosol spread from dropping near a vent, which can then be spread throughout the house, or a clothes dryer or heating vents from a garage. So even if the animals are not in the room, maybe they're in the garage or they're in a different part of the house, the antigens can still be spread throughout the house through vent systems. This can also occur from exposure to feather pillows, down comforters, coats. And interestingly, although it's not entirely known why, but bird fanciers or lung or HP induced by birds carries a worse prognosis than farmer's lung. It could be because there's often closer exposure, higher dose and duration, and persistence of the antigen in the home environment, but it's more likely to cause fibrotic disease and overall carries a worse prognosis. Okay, another major category is ventilation and water-related antigens. So antigens from microorganisms that colonize forced air systems, heated water reservoirs, humidifiers, vaporizers, swimming pools, hot tubs, water-damaged carpet, musical instruments can be reservoirs. And this is often various forms of fungi and a Mycobacterium avium complex, which is referred to as hot tub lung. Hot tub lung is a hypersensitivity to MAC, similar to HP, but there are some differences. Histopathologically, the granulomas are more well-formed than what we see in HP, where they're overall looser. Okay, another main category is veterinary work and animal handling. These are laboratory workers who are exposed to the urine or serum of veterinary animals, workers that work with pelts from rats or gerbils, or that have exposure to other types of animal pelts that may sew the fur together and have exposure to proteins from the animal furs that way. Another main category is grain and flour processing. You could imagine while processing the grains, colonization from various microorganisms can occur. These antigens can be easily aerosolized in the dust that occurs and then inhaled, and with repeated exposure can lead to hypersensitivity pneumonitis. Lumber milling and construction is another way that organic antigens can be aerosolized, usually through when trees and plants become colonized with mold, and then it gets aerosolized into the environment during processing and can cause disease. And then finally, there are some inorganic antigens that have been associated with the development of hypersensitivity pneumonitis. These are synthetic antigens, often still environmental or occupational exposure related. And oftentimes when you get chemicals into the gaseous phase, which allows them to be inhaled and then can cause disease. There have been some reported cases where there's thought that some of these more inorganic related hypersensitivity pneumonitis cases could be because of bacterial contamination. And so ultimately, maybe most of it goes back to organic proteins, but certainly it has been linked to chemicals as well. Okay, so these are all very common antigens, and not everyone exposed to these develops disease. So why do only some people develop HP? So clearly the antigen is not the whole story. It also depends on the exposure dose, environmental cofactors, the host genetic and immune factors. And so there is some ongoing work and studies into better understanding what the genetic predisposition is to HP. There's some genetic studies that have suggested that many polymorphisms are linked to antigen presentation, and the polymorphisms are on the major histocompatibility complex, which is how antigen-presenting cells trigger the immune system, and that that may explain why these patients have issues with the development of tolerance to certain antigens. Interestingly, fibrotic HP shares some genetic polymorphisms with other interstitial lung diseases, including IPF, with mutations associated with shortened telomeres and MUC5B. And just to sort of further emphasize the potential here for a genetic predisposition, there are familial clusters that have been reported even when affected family members live far apart from each other. So it is difficult sometimes maybe to separate between the environmental exposures and the genetic exposures, but there have been cases with family members that don't live together that both develop hypersensitivity pneumonitis. So I want to briefly mention the working theory on the immunopathology of HP. So antigen-presenting cells, like macrophages and dendritic cells, encounter antigen in the air spaces or in the draining lymph nodes of the lung, and they become activated when they encounter the antigen. They in turn activate naive T cells, which multiply and secrete pro-inflammatory cytokines and amplify this immune response. So normally there are these T regulatory cells which suppress the immune response and promote tolerance. And so they're really important in the development of tolerance to inhaled antigens. It seems that in hypersensitivity pneumonitis, these T regulatory cells are dysfunctional and they're not able to suppress the inflammation. And so it continues to amplify. But why some people develop antigen-specific Treg dysfunction is not well understood. So that's a remaining question in the field and an ongoing area of research. So B cells are also activated by antigen. They mature into plasma cells and they make antibody, which complexes with the antigen to make some immune complexes, which are also not a major part of the disease, but seen in HP. So in addition to the dysfunction of Tregs, there's some evidence that a second hit in the environment may further promote inflammation and explain why some people tip over into disease. So studies have suggested that second hits include viral infections, which have been found in the distal airways of patients with HP, such as influenza infection. Pesticides may be a potential second hit in the case of farmers' lung development. And then air pollution also has been associated with increased HP cases, as it may reduce mucociliary clearance and increase inflammation and sort of tip the balance over into disease. A very interesting side note is that HP is found less frequently in smokers, actually. This phenomenon is not well understood, but it may be related to the effects of nicotine on the ability of the antigen-presenting cells like macrophages to activate in response to inhaled antigen. There's some interesting data that this association may be reversible because there does not seem to be a difference in former smokers in the development of HP. Okay, so what happens in the lung after the immune system gets activated? The lungs of patients with, so this is sort of non-fibrotic HP, are very inflammatory, and this inflammation is mostly lymphocytic. There is the formation of loose granulomas that are found on pathology if a biopsy is performed. Some patients go on to progress to fibrosis. This can appear quite similar to other interstitial lung diseases, including IPF, in both in clinical presentation and imaging. So one of the main take-home points from this talk is really to include fibrotic HP on the differential for a new ILD that you might see in clinic or in the inpatient setting. And again, why some patients with HP end up fibrosing is still being studied. There certainly is a higher rate with bird antigens, as I mentioned, but there's some potential similar mechanistic themes that are seen in patients with IPF, which is premature aging, shortened telomeres, increased evidence of senescence, and transition to a Th2 predominant immune response. Okay, so how do we make a diagnosis of HP? So the diagnosis is based initially in the context of respiratory symptoms, often dyspnea and cough. And it's really a combination of history, imaging, and then BAL and/or tissue data. So to have a high confidence in the diagnosis, there should be some evidence of exposure to an antigen, either by history or by serum IgG antibodies, and a radiologic pattern consistent with HP. A BAL lymphocytosis is supportive, but not necessary to be confident. But if you're missing one of the first two, either you don't have exposure, an antigen, evidence of an antigen, or the radiologic pattern is not consistent with HP, then the confidence in the diagnosis is reduced. And a lung biopsy or additional tissue data could be helpful to confirm the diagnosis. So we're going to take these sort of step by step. So whenever you have a patient where HP is on the differential, and I would sort of include any new ILD in this category, it's really important to obtain a detailed exposure history. There are some standardized questionnaires. They may be helpful, but none of them are really validated. And so many providers just have a list of things that they run through that include pets, especially birds, any kind of exposure to bird antigens, including commonly used items like feather pillows, duvets, sleeping bags, jackets, wind instruments, any water damage to the home or environment, other water sources like hot tubs, jacuzzis, or swimming pools, air conditioning, humidifiers, and then all kinds of workplace exposures like lab animals, veterinary work, farming, and then chemical exposures. People often know the answers to these questions. Sometimes things like mold can go unrecognized. There are companies that will inspect the home. They are expensive, but they will come in and examine and sometimes can be helpful in finding exposures. Okay, so antigen-specific serum IgG antibodies can be sent from the serum of patients with suspected HP. It's really important to note that these are markers of sensitization and exposure and not necessarily disease. So because of this, there can be high rates of false positive tests, and people may show evidence for exposure that may not lead to disease. So the tests need to be taken in context. I'll also make a note that skin testing is not necessarily helpful. This usually a test for IgE rather than IgG. And specific inhalational challenges are not recommended because they can induce worse disease, and this testing has not been validated. Okay, so radiology can be extremely helpful at moving HP up or down the differential. A typical pattern for non-fibrotic HP usually includes one infiltrative pattern, such as ground glass opacities or mosaic attenuation, and one small airways disease pattern, which includes central lobular nodules and air trapping. So it's really important here to always get a high resolution CT so you can get both inspiratory and expiratory views. And on this example here, you can see central lobular nodules in A, and a nice example of ground glass opacities and mosaic attenuation in B. and then some air trapping with expiration in C. The most specific radiologic finding for HP is called the 3-density sign, and includes 3 different attenuation areas. So there's increased attenuation or ground glass marked by this yellow arrow, decreased attenuation suggestive of areas, small areas of obstruction with the white arrow, and then some normal areas. So this constellation used to be referred to as head cheese, but since I put a little picture in here of head cheese, a meat jelly with multiple different textures and areas of attenuation. Most of us are no longer familiar with this. It is now referred to by our radiology colleagues as the 3-density pattern. Fibrotic HP differs from non-fibrotic HP in that there is more diffuse reticulation and traction bronchiectasis on imaging, findings consistent with fibrotic changes. Classically, fibrotic HP spares the bases, so classically it can be a difference between this and UIP or IPF. Classically has a mid and lower lobe distribution, but up to 1/3 of the cases have been reported to have a UIP pattern. So we look for things like more diffuse distribution and evidence for air trapping, which can be distinguishing features, central lobular nodules, but these are not always present in the fibrotic stage. This is just a summary slide on key radiologic findings in both non-fibrotic and fibrotic HP from a review by Dr. Moisey Selman, one of the real giants of the HP field. Okay, so the ATS guidelines does recommend a BAL for lymphocyte count, but there's low confidence in effect. So I tend to do a BAL when infection is also on the differential, so you can send cultures. And this can sometimes be the case with non-fibrotic HP. And in that case, I would always send a cell count and differential with the cultures. And so if that's done, elevated lymphocytes in the BAL fluid is characteristic of HP, but again, it's really not specific. And the ATS has, depending on the studies, you'll see anywhere from 20 to 50% lymphocytosis reported. The ATS guidelines recommend greater than 30% as being consistent with diagnosis of HP. There are many caveats to this. It's not sensitive or specific. If CD4 and CD8 subsets are sent, a low CD4 to CD8 ratio has been seen with HP in contrast with other ILDs, such as sarcoidosis, which have a high CD4 to CD8 ratio. And a large systemic review was done a couple of years ago, which not surprisingly found the percent of BAL lymphocytes was higher in HP than in other ILDs, including IPF and sarcoid. And in the non-fibrotic HP, there was a higher sensitivity and specificity with that finding than in the fibrotic HP. So when the clinical Okay, I apologize for that brief interlude, but getting back to the diagnostic workup here. So there's several different ways of obtaining tissue to sort of confirm the diagnosis of hypersensitivity pneumonitis. The first one being a transbronchial biopsy, and the ATS guidelines recommend transbronchial biopsy for diagnosing non-fibrotic as a higher yield than fibrotic HP based on the fact that the disease is more diffuse and there may be a higher yield because of granulomas that you might find along the airways in this disease. As you can also do a transbronchial cryobiopsy, which has been shown to have a higher diagnostic yield as compared to transbronchial biopsies, but carries with it a higher risk of complications, including bleeding and pneumothorax. So the ATS guidelines recommend consideration in experienced centers. And then finally, the most invasive of the biopsy options, a surgical lung biopsy, does give you the biggest piece of tissue and has been reported to have sort of the highest diagnostic yield, but also carries with it higher morbidity and mortality risks as it is more invasive. And just to make the point that it can be most helpful, I think, when other ILDs are on the differential, including UIP, such as having more of a UIP pattern on CT. So if a biopsy is done, what is the classic findings? The typical histopathologic features of HP include a bronchiolitis with lymphocyte predominant inflammation and loosely formed granulomas and multinucleated giant cells. In more fibrotic HP, as you might imagine, typical histopathologic features include more of a bronchial-centric fibrosis, sort of dense fibrotic regions, often adjacent to the airways, and less overall inflammation. Okay, so the ATS has put out guidelines for assisting with making the diagnosis of HP, and the algorithm that they have published is very similar to the way in which I've talked about this. You have a patient with newly detected interstitial lung abnormalities on imaging. You go through exposure assessment, and if they have a high resolution chest CT scan, that is recommended first. Consideration can be made for a BAL with focus on looking at the lymphocyte cellular analysis with or without a transbronchial lung biopsy. And then at that point, you really have to think about whether exposure has been identified, what the pattern looks like on radiology, whether or not you have BAL data. And if you have all of those things, after undergoing a multidisciplinary discussion, you have an exposure, you have a typical pattern, and you even may have BAL lymphocytosis, there can be at that point high confidence in the diagnosis of HP. But all other combinations, which is usually where we're operating in, you have sort of an unclear diagnosis. And then we go back to reconsidering exposures, undergo a multidisciplinary discussion, and that's with pulmonary radiology and pathology. And then consider whether a more invasive, like a cryobiopsy or a surgical lung biopsy, is indicated, and then go on to try to assess how confident we feel in the diagnosis. And so this is a table that is in these same ATS guidelines from 2020 in the Blue Journal, weighing the different aspects of the combinations of features with a heavy emphasis on pathology, as it should be. So the pathology can really make you much more confident in the diagnosis of HP, but in the absence of pathology, the combination of exposures, of a pattern on radiology, and if we have BAL lymphocytosis, we try to put those combinations together and to determine the confidence that we have in the diagnosis of HP. Okay, so now I'm going to talk a little bit about treatment. And so the first thing and most important thing is to try to reduce exposure, ideally eliminate exposure to the antigen. And this can involve removing birds or antigen, feather bird bedding, et cetera, from the house. This can be quite difficult because the antigen can persist despite cleaning. Avoidance of hot tubs, if that's felt to be the exposure, sterilize water that they have, either humidifiers or vaporizers. And this may sometimes require relocation to either a new job or a new home. For acute HP or non-fibrotic HP with minimal or transient symptoms, complete antigen avoidance can sometimes be sufficient. But as I mentioned earlier, this is not always possible, and up to 30% of cases, the antigen is never found. Okay, so what if we do if avoidance is insufficient? And here we consider steroid course. And so this is often done for persistent symptoms, abnormal lung function tests, hypoxemia, or radiologic evidence of more extensive lung involvement. And so first-line steroids is generally recommended to be prednisone at a dose of about 0.5 mg per kg per day. This is recommended as an initial dose for a couple of weeks with a taper over over 4 to 8 weeks. Although I just want to mention that the dose and duration has never really been formally studied. And then the thought is, based on the studies that we do have, that this can accelerate the initial recovery, but may not really change long-term outcomes on its own. And so here's a study that's now over 20 years old, but looked at 36 patients with farmer's lung who were randomized to either 8 weeks of prednisolone or placebo. And as you can see here, they were followed for a year, and there was some improvement at 1 month, particularly in the DLCO, but no significant differences in their lung function after that. And by about a year, they had sort of normal. They were very similar. So suggesting perhaps there's some upfront benefit, but may not be long term. Just wanted to emphasize again that there have been studies that have shown that the existence of fibrosis with the diagnosis of HP portends a worse survival. This has been studied. This was a study in Chest in 2008 that looked at patients with fibrosis just having overall worse outcomes. And there's been, as I mentioned, no prospective studies of corticosteroids, but generally, even in fibrotic HP, it's still recommended that that prednisone at a similar dose, 0.5 mg per kg per day for an initial 4 to 8 weeks, followed by a tapering down to a lower dose, like 10 milligrams by 3 months, is recommended. And there have been some studies with use of steroid-sparing agents like azathioprine and mycophenolate, which have been associated with improved lung function and reduction in prednisone dose. In this case, there was a more significant uptick in predicted DLCO over time with the initiation of MMF or azathioprine. This is another retrospective study of using steroid-sparing agents, MMF and azathioprine, which showed that the earlier introduction of steroid-sparing agents were associated with both a reduction in prednisone dose and also a reduction in treatment emergent adverse events, which were largely GI related, but overall didn't show a difference in lung function decline or survival compared to prednisone alone, but just were sort of better tolerated and reduced side effects. In fibrotic HP, there have been some case reports of patients treated with rituximab. So this is one case of a patient that was refractory to steroids and Cytoxan use and was treated with rituximab and showed improvement of lung function over time. Of course, this is just one patient, but they did report positive results with the use of rituximab in refractory fibrotic HP. And then this is a slightly larger study of 23 patients. This was a French study that was published in 2020 that showed that all the patients got rituximab, and they had a variety of responses after. They reported about a 30% response rate to rituximab. They had about 30% of the patients, 7 of the 23 patients they studied, had either stable or improved FVC 6 months after rituximab therapy. So some suggestion here that rituximab is an option in these patients. But the biggest study really to change the treatment algorithm for patients with fibrotic HP was the InBuild study, which was published several years ago now in the New England Journal of Medicine, which treated patients with progressive fibrosing interstitial lung disease with nintedanib. There was that patients with HP were included in this study. What they showed was that, very similar to the study that was done with nintedanib in patients with idiopathic pulmonary fibrosis, that there was a decline, there was a reduction in the FVC decline over time. So it performed very similarly to the patients with that had been treated with IPF. And they did a subgroup analysis with patients that had UIP-like fibrotic pattern on their CAT scans, and there was really no difference in outcomes between those patients and patients that had HP but had a more classic HP pattern on their CAT scan, so suggesting they behave differently regardless of their radiologic pattern. And I pulled this from the supplementary portion of the study, just to show that about 25% of the patients in this study had hypersensitivity pneumonitis. So it was one of the best represented subgroups or diseases in this study. As Dr. Shea mentioned in his earlier talk, there was quite another large portion of the patients studied in the InBuild study were connective tissue disease associated ILDs, but HP was pretty high up there as well. Okay, and just one mention about transplantation, which is an option for patients with progressive fibrosis and hypersensitivity pneumonitis. The same indications exist for transplant as other lung diseases. There's been reported pretty good medium-term survival after transplant, perhaps even better than patients with IPF, and perhaps this is because patients with HP tend to be a little bit younger than IPF undergoing transplant. Disease recurrence can occur, but the rates appear to be relatively low. But it is important that whatever the initial inciting exposure is felt to be, that antigen is removed from the environment post-transplant, just to try to reduce any chance of disease recurrence. Okay, so take-home points for HP. This is an immune-mediated lung disease, which is felt to be triggered by a variety of inhaled antigens in susceptible individuals, whether this is a second-hit environmental exposure or genetic predisposition. We don't know. We're not really currently testing for those things, but in the future, we may, and I think that would be really, really interesting to learn. It's important to search for the offending inducer and try to eliminate it from the environment. Immunosuppression may help, in particular in non-fibrotic HP, but some patients do develop progressive fibrosis, and in that case, antifibrotics may help. The most data that we have is with nintedanib, and really important to include fibrotic HP in the differential for a new ILD. And finally, I'll just leave with the sentiment that a lot more people live with birds than I think I really appreciated. And birds are really one of the top inducers of hypersensitivity pneumonitis. So it's important to find the bird, and sometimes removing the bird from the environment can be really, really helpful at stopping the progression of lung disease. So I'll stop there.